Thank you for involving me in this event. I'm really proud to be a part of this event. I'm talking to you about insulin delivery technologists, and I have nothing to disclose. My outline, I'm going to start with some introduction. We're going to talk about the evolution in the insulin delivery technology, the current situation and with its impact and challenges, and what is the emerging technologies and what's in the future direction, and the summary. So as introduction, why insulin delivery is matter, and why we are talking about the insulin technology and its evolution over these years, let's say 100 years since the discovery of insulin, because since 1921, we know that diabetes was a fatal disease. Type 1 diabetes was a fatal disease. And whenever patient is diagnosed with that, doctor can do nothing unless just advising the patient for a very low restricted diet, low calories. It could be down to 450 calories per day. And that causes a severe cachexia, severe failure to thrive in pediatric age group. As we know, it's more famous in pediatric age group. And usually patient gonna be like bedridden, waiting for death. So the flip in this situation from fatal disease to having your normal life, having your normal activity, even being famous as an actor, as a singer, as a presenter, as a foot player, or any important member in the family. I'm sure that among you, some of type 1 diabetes patient who is very important in your life, and they are living a normal life or semi-normal life, all of this because of discovery of insulin, which was almost 100 years in 1922. So that's why it's very important to talk. It's the evolution of its delivery. And it was started, as you know, by the physician, a surgical physician, with spit and beating from the dog. They discovered insulin from the dog, and they inject the insulin again in this dog that results in normalizing of the glucose. And since then, there was a lot of trials, but the first human trial was in Toronto, Canada, for pediatric age group, was 14 years old boy in Toronto Hospital. It was the first human to receive insulin. And the first trial was failed because of severe allergy to the insulin. As you know, before it was extracted from animals before it's a human. But the second trial was successful and was normalizing his glucose. And from that, that doctor took the Nobel Prize for his discovery, and the journey was starting for the evolution and how to deliver this important medication to type 1 diabetes patient. And this evolution in insulin itself, it was first from the dog to the cattle to the pig. Late then, by 1982, it was the human engineered insulin, and since then we are using this technology. However, it was started at the beginning with a glass needle, which was really painful. Then there was evolution in the using of the needle itself, using the disposable syringe, which was less painful, and it was used for a long time. Even there was what we called backpack insulin pump, which was very huge. As you can see, it was you cannot do your usual activity using this bag, and that's lead to more models of insulin till they reach by the 80s the disposable insulin pen, as which is famous nowadays. However, after discovery of this insulin and having the pens, we know that what's matter, that the end point and the goal, that we need to control the blood glucose to decrease the all complication of type 1 diabetes. And that was emphasized by the famous study, the diabetic control and complication trial in 1987, that emphasize the need for intensive insulin therapy instead of just having insulin as twice daily injection. All the study emphasized that having intensive insulin therapy will reduce the A1C in all age group, as you can see here. For the all subject, there was decrease in the A1C from 8.8 to 7, or in the adolescents between almost 10 to 7.7, and for the adult 8.5 to 6.7 even. And the ultimate end result of having more controlled glucose lead to less complication of the retinopathy, nephropathy, neuropathy as a development or as a progression. However, that's why one of the current insulin technology we have is the insulin pen. I think all of us know this pen. This is the most common. There is two types. There is the long-acting. It's a different brands. However, the Glargine and Tresiba, one of these two more famous to be used. The green one and gray. And the rapid-acting insulin, which is the Novoben, most likely patient using, or the Lispro. Whether you are using the long or the short-acting insulin, the disposable pen, this pen usually it's combined. The advantage of it, they combine the syringe and the insulin unit together instead of having in a syringe as it was before. I think nobody's using that anymore. And it's a very accurate dosing. You will not take it by the syringe, so you just dial the number that you are needing, then you can inject yourself. It's user-friendly. Only thing that you have to do, the twist a new needle, dial, injection through the needle, and that's it. And it's color-coded. It's very important because we know that the long-acting insulin is different than the rapid. So sometimes without reading, just by the pick up the color and to take the right insulin. It's portable. You can take it anywhere. Less obvious, and this is very important because, especially because I'm a pediatrician dealing with teenage, some of the teenage, the most important thing for them to hide the disease from their colleagues, and they don't want anything in their body that indicate that they are type 1 diabetes. So if something that that they will have with no indication all the time that they are diabetes, it will be more convenient for them. And so it can be digital application that I'm going to talk shortly. However, it can be disposable or reusable. I'm going to show you. This is the disposable bin. Usually, and among all hospitals, we are using the disposable bin. It is preloaded with the insulin itself, and usually it lasts for 28 to 32 days. After you finish, you have to throw the pen. You cannot use it again. However, there is another pen which is reusable, and this pen usually you have to load it with the cartridge, and the pen you're gonna use it even after finishing of the cartridge. You can use certain types according to the certain type of insulin to be here, whether it's a Tresiba or Novo Rapid, and it's usually according to there is some colors, so you can differentiate which insulin you are using. It's more expensive than disposable, but usually we use it for pediatric age group because it can dial the half unit. Maybe for adult it's not that important, but for pediatric, especially for toddler, 1 unit can cause hypoglycemia if it is given. So the mother sometime before using of the pump, she need to give this half unit. This is the pen, and it's digital. It has some advantage of, as I mentioned, the number of unit that was last injected and the last time it was given. And as I mentioned before, it's very important for toddler. Usually, it's for the hospital with limited resources to the pump, because we know the toddler there is no FDA approved pump except for the Omnipod. The other pump, you can use it only if it is 6 years and above. So for toddler, if the Omnipod is not available, it's gonna be really a problem solving to have this injection with the half unit. However, there is another smart pen. Actually, I'm not aware if it is available. I haven't seen any patient using this N pen, but it's available in the market of the US, and have some advantage of being Bluetooth connected with the mobile apps, and it can help the patient in calculating the dose. If you are putting the setting for how much the 1 unit gonna decrease, what we call it ISF, and how much 1 unit gonna affect your carb, which called ICR. It can help the patient to calculate the doses and to track what was the last dose taken, and even it can you can also have a data for all insulin that have been taken before, so to be provided to the healthcare provider. This smart pen, as I mentioned, it's helping the calculation if you have the setting. It also will tell you about active insulin. If your last injected insulin was, for example, within 3 hours, it will alarm you if you are taking another dose. That's to prevent any stocking of the insulin and hypoglycemia. However, as I mentioned, it can be also half unit doses. And also it will give notification whenever there is a near expire for the insulin or the temperature is high, as an alarming. So this is in general the pens that's available, what's the commercial one or the smart one. But we know that the disadvantage of having pen, the most common disadvantage is the frequency, if it is not the pain. Some of the patients, they will not complain from pain, but they will complain of that it's not really convenience for them to have injection whenever they want to eat. Sometimes they decide to have a snacks after the main meals, and we know if they took this snacks, it might lead to, or most likely it will lead to hyperglycemia if it is taken without counted insulin. So this is really disappointed for pediatric, because especially the caregiver and the mom will be disappointed that she doesn't know if her kid's gonna ask for a snack. If she give more insulin, he might not eat, and they end with hypoglycemia. And if she give and if she didn't give, he might eat and lead to hyperglycemia, and that will cause the yo-yo effect, what we call it, the big variability in the glucose. The other thing that this insulin should be, whenever she or the patient move or going to school, whatever, should be in certain temperature. So they feel that they have to have a certain bag with ice or something, or cooling, so it restricts their freedom from moving without these pens. And the cost for some limited area and countries is also expensive to use this pen. However, even with this disadvantage of this technology, the technology solves its disadvantage. For example, there is what's called iPort, and this iPort look like an infusion cannula that with nothing, that you have to take the injection and insert the insulin, so you don't need to inject yourself every time. We tried in pediatric age group, but usually I don't know, it wasn't that successful, because in pediatric we are using very small doses. What we noticed that you have to give more than what you need, because some of the insulin will stuck in the cannula itself. And that's lead to some randomization. So sometimes you're gonna give 1 extra unit or 2 extra unit that might lead to hyper or hypoglycemia. So although it's available, although the idea is look very good, but I don't know, from my experience, I haven't seen patient who's, rarely I have seen patient that really comfortable using the iBoard. However, the cooling, there is also some technology that solving this issue. There is like here cooling used by battery, like a mug that can keep this insulin, whether you're gonna use it for pen or the insulin syringe for the pump. While the patient on the beach or whatever, he can use this kind. It's available even on Amazon, I think, and some company they offer it. And patient they really like it because it can save having eyes that might not last for a long time. And there is also some caps that just you cover the insulin pen with the cap that we're gonna keep the temperature, so which is good also for to solve some of these challenges, or the freezable bags as before. And as I mentioned, the costs depend on the area. If it is limited, it can even these pen can be expensive for them. However, as we mentioned, there was a continuous evolving in the technology until we reached the bomb. Instead of having this pen, so it was the first bomb by the Medtronic, and the evolution was continue that I will talk shortly in subsequent slide. And there was some studies that compare, especially in pediatric age group, between between giving sub-Q injections or having insulin pump. And what they mentioned in their study that, of course, there was a significant improve in the glucose control and in patient development, pediatric age group, if they are using the pump instead of the multiple daily injection. And even in pump itself, the pump for this is the famous kind of pump. We have the Medtronic here in Saudi Arabia and the T-Slim. We have the Omnibot, the Dash. The 5 is available in some patients, some stores, but it's not by the agency itself. And there is the other pump like AquaCheck. I will come shortly. However, the idea of the pump, what is the pump? The pump is a continuous insulin infusion. It's a small device that will give insulin in two ways. The first way, it will be continuous, what we call it the basal. And the second way is by giving the boluses. And usually we need the bolus either a pre-meal or as a correction. However, to have this infusion, you need a catheter which is gonna be inserted in the skin to the fatty tissue, and we need what's called the infusion set, which is the tube and the needle combination. We call it infusion set. However, it could be integrated with the CGM or not, according to the type of the pump. And the age is different, as I mentioned. For example, Omnibod is approved for all age group of pediatric and adult, while Medtronic and T-Slim is still 6 years and above. And this is how it's look. This is the infusion. This is the infusion set. This is the catheter through the skin and fatty tissue. This is the tube that will deliver the insulin. And here is the pump where the controller and the cartridge of the insulin. And this is what I mentioned by giving continuous, which is the basal, and this is the bolus as a pre-meal or as a correction. And by this, we want to mimic the physiology of the human pancreas by secreting certain amount of insulin all the time, and secreting more insulin when we eat and whenever there is hyperglycemia. However, this tube, if it is not there in certain kind of pump that I will mention, we call it the batches or tubeless. So this is as a concept. So it's divided as two major group. We can divide it to tube insulin pump, which is called tethered pump. And this is how it's look like. This is the pump. This is the infusion set that's gonna be always connected to the patient. And this is the tube that will deliver the insulin. And we have the tubeless insulin, which is untethered, like here. This is the pump where the insulin is here, and here is the controller, and the connection gonna be through the Bluetooth. And This is about the type 1 diabetes management and outcome from the exchange that despite having the pumps, despite having the insulin injection and everything, and despite the recommendation of ADA for the control, in 2019, the study published mentioning that only 17% of pediatric achieve the goals of the ADA of the target A1C, and only 21% of the adult achieve the ADA, which means that despite all that technology at that time, it was really difficult to have the goal of having A1C less than 7 for the pediatric and adult. And that's enforced the technology to have more, to be integrated more, to have this control. So this is that led the development of the CGM with all its type. And as we see here, this the reported, and we can see the glucose all over the time instead of the previously having just some reading. And from that time, 2019, the ADA just published her new recommendation about the control and how it's look like. It's not anymore that hemoglobin A1C should be 7 or 6.5, and now they are talking about the A1C. So this green zone, how is the reading between 70 to 180, how much percentage it should be. So the recommendation to be according to which patient, for example, here they put for you type 1 and 2, if they are older, they have different goals, if they are pregnant, and etc. So here, most of the patients, let's say they are in this category, so 70% within the green zone, and less than 5% as hypoglycemia, less than 5% as very high glucose, which is defined as 250 and above, and less than 25% of having high reading. For that, and to achieve this green, that's led the technology to be more evolving, to have what's called automated insulin delivery. And what we mean by the automated insulin delivery is that the insulin will affect your glucose, and the glucose will send the data to your sensor. The sensor will let changing in the algorithm. Algorithm, that means this is look like an equations that gonna be done by the pump. It will act according to blood glucose. For example, if it is high, to give some correction; if it is low, to suspend the insulin, and this will affect the insulin delivery, and etc. And this is what's called automated insulin delivery. However, that's let us define the insulin pump again into different type. So if you have the sensor, it is not connected, not communicating with the pump, we call it open loop system. If we have the sensor that is communicating and pump or the controller will affect the insulin delivery, this is what we called closed loop system, which is hybrid. Usually I put actually DIY before putting the hybrid officially, because I think in my belief the do-it-yourself they are the first one who integrate this technology before it was announced by the famous company. However, we call it hybrid because we are still need the human or the user to put the pre-meal carb. So since the user still need to enter some data, that's why it's called hybrid. It's not totally closed, so the sensor will not totally communicate with the insulin, with the algorithm, and algorithm will communicate with the sensor alone. No, we need a pre-meal input from the diabetes patient, so that's why it's called hybrid. And we are looking now for the new technology, which is the fully closed, where you just have to have your pump, and there is no announcement and no intervention by the user for the pre-meal boluses or correction boluses. And this is the famous pump we have here in Saudi Arabia. For the hybrid closed loop, we have the Minimid 780 from Medtronic and T-Slim from the Tandem. And as I mentioned, they can be used from 6 and above, and they minimize the hypo and hyperglycemia. Usually, they help to maintain the glucose in target and time in range. They have different algorithm. Each company have its own algorithm. What I mean by algorithm is the equation that how we're gonna deal with the glucose. However, you can adjust the basal rate insulin. It can adjust it, and it can give automated correction, pausing the insulin infusion. But still, as I mentioned, it's the user still required to manually program the boluses pre-meal, and that's why it's called hybrid. And we have this Omnibot. This is the batch where there is the same idea of other insulin, but there is no tubes. And there is the AquaShek. This is 5, which is hybrid, and we have the AquaShek, which is tubeless. I don't have idea about the Aqua because I don't know. It's more famous here, the Omnibot, so we are more familiar with it. And this is in comparison about the size between both. General feature of it is the same idea, but as I mentioned, only what you need is the BDM, which is the controller. What I know now, even the new generation of the bomb, this one can be maybe it's not a must. You can use the mobile as a controller as well. And you need the board where the insulin is here and just a Bluetooth connection. Sometimes there is some troubleshooting for the Bluetooth connection. However, the BDM is the controller. It can set even a 0 basal rate, and it can give fractionated for the carb ratio. Patient like it, especially for pediatric, because you don't need to disconnect it for swimming or for taking a shower. And there is no tube, so they are not afraid while sleeping that it might disattach from the patient. So it's very friendly for the pediatric age group. And the only what you need just to put insulin inside the pod, put it in the body, then control it with the pod. It's very easy, very user friendly. This is if it is Dash. If it is Omnibot 5, which is the hybrid, you have to be communicated with the sensor. So if it is Dash, as I mentioned, if there is no communication with the sensor, we call it the open. You have to put the reading here. You take it manually from the sensor, and you put the reading, and accordingly she will calculate. While if it is connected, there is nothing needed to enter it, but it will communicate and adjust, as I mentioned, as the other smart bomb. However, there is I don't know, maybe 2 years ago in US they launched the fully closed loop system, which is the eyelet. It's they don't need to put pre-meal. You don't need the carb count to be accurate, but you need just to announce that you are going to eat, and you have to mention if you are gonna eat breakfast, lunch, or dinner, and to choose if it is similar, more or less. So there is still a need for the user, but there is no need to count and etc. And but there is still challenges for this pump as a comparison to the pre-meal boluses, that there is some postprandial hyperglycemia, and there is some challenges with the exercise. The studies is not supporting that she's superior for the manual pre-meal. What they mentioned that the manual pre-meal have less peak postprandial hyperglycemia. However, even with this, and even if it is not superior, I think it is still worth for this patient, for maybe pediatric age group who is missing the doses, because I know that in my clinic, some certain patient, they will not put the pre-meal, and they are dealing with the pump inappropriately. So I think they might get benefit when we get this in the market, because you don't need to announce your meal. However, what's the impact of these technologies we need? There is a benefit. One of the benefits, as I mentioned, all studies supporting that is the control is better. It's less complication as a long term. It's easy to use. It's not that some of the bombs, it's very easy to be used. there is increase in the freedom. What I mean by freedom, especially in food, they don't have to inject with each snack or food, and quality of life. I remember every time when I get a patient who's new for the bump, I ask them how the bump changed their life. And I don't know, surprisingly, that most of the parents mentioned that finally I get to sleep. So what I mentioned for patient who against the bump, because they have good A1C or good time and range, that you're having that with a lot of work and hard work, and what's matter now is the quality of life. Maybe after the bump, you're gonna appreciate how your life can be easier and better. And the reports, of course, having this technology will help the care provider to be communicated with the patient, even if they are far away, adjusting and giving some advice. For the bump itself, as I mentioned, it's cost effective for the quality of life. It's flexible. There is some freedom with the food, less hypoglycemia, less variability. Even some studies mentioned there is a decrease in the requirement of the insulin, but can be up to 30% when they compare the insulin versus the injection, and less complication in the injection side. However, this is some of the reports how we can see the setting in the report. We can see day by day. This is for the smart pen. We can see day by day the glucose, the carb entry, how much she's taking, how frequent, if there is any problem, how frequent they change the set, and everything is clear in the report. And this is study when they they study how was the automated insulin delivery affect. This is a systemic review meta-analysis, and all the study was supporting that the automated insulin delivery enhanced the quality of life of the patient, especially for pediatric. Regardless what was the algorithm that have been used, all of them was with significant p-value. However, each technology have its advantage and disadvantage. There is still some challenges. We know that anyone having bump, he know that there is a disadvantage. Beside the accessibility, we know the insurance might not agree for each patient because of the high cost. It's not available in everywhere. The patient itself, it have to adapt and to accept the bump sometime, even if it's available in the hospital. The patient might not accept it, or the caregiver, they think it's need a lot of training, a lot of technology. Dealing with too much technology, just let them, I don't know, scare from it. They always fear from the failure, and it can happen. And that's why we always tell them that you need what's called a backup plan whenever there is a failure or you are outside the resources. And the reliability of the technology itself, cybersecurity, and sometimes they are afraid from how if they depend on the technology or the updating, the software, the operation system itself. We know, and all of this technology can have a hanging or a failure, and it might, I don't know, make your day upside down, or you might not sleep the whole night because the pump is not working properly, the sensor is not communicating with the pump. I know there's some disadvantage. Almost all of the patients they went through, but this is the nature of technology everywhere. However, the insulin itself, also one of the disadvantage is being attached 24/7. Some of the patients, they don't like this idea that there's something attached to me. They need, I don't know, like a model or something, a trial before having a bump for life. Other thing is that they are always asking about if I'm gonna be free for swimming, the football, especially for boys who's teenage. Usually number one saying no for having a bump is I'm a player, I play a lot, and I don't want anything that will affect my activity or my normal life. And also some for the teenage, the psychological body image, they don't like something to indicate for people that I'm type 1 diabetes. Sometimes also it can cause over treatment of hypoglycemia, especially if the setting is not that working well, or especially if you have for the automated, you bolus after eating while the pump already gives some correction. This over the dose, so it's gonna have double dose that lead to hypoglycemia and lead you to have juice or something, so that lead to over treatment of the hyperglycemia. Sometimes patients, they feel that they have to be awake, they have to be aware all the time to monitor, because they are afraid of the risk of a leakage, or a risk of kink of the cannula at night, and that might lead to the diabetes. This is a nightmare for any caregiver, that if any kink or something happen, we know that we're gonna spend our night in the ICU. And that's why we always tell them, whenever you are far away, please take a backup supplies, because you never know what's gonna happen there. However, I always tell my patient, even if you are afraid from having sport, there is some famous player who is having their life normally, and they are famous, and they are using Mabab. It's never restrict your life. But you know, some of them, they are still not convinced. The pump, as I mentioned, could be failure. The site itself, there can be kink or leakage. Skin sometimes get infection, irritation, tenderness, and this is of the complication. So that's why this open a question: what's the area of improvement for the coming pumps? Maybe we need more effective closed loop. We need that capability of all of these devices with our complex scenario. Maybe we need it to be adjusted for everyday life, like exercise, sleep, variability in the meal. Maybe we need a better sensors, because a lot of problems that might arise not from the pump itself, from the sensor, from the reading, hanging, I don't know. So maybe we need a better sensor, maybe built in with the pump itself. Maybe we need a faster insulin that can have switch rapidly, switch on and off. Or we need another thing with the insulin, like a glucagon or other hormones that can help and produce hypoglycemia. Maybe we need more advance in the algorithm, because there is not only variability between patient to patient, there is a variability in the patient itself and his activity. And I think all these things, and the question it's gonna be raised with the next generation of the insulin that I'm gonna talk hopefully shortly. This is the most famous technology we have here, and used by type 1 diabetes patient. However, in the literature, you might see other technology that is there, but it's not really famous. I'm just shortly pass by it. For example, the artificial pancreas. This is in Japan. This is minute by minute built-in glucose monitoring, and they use it only preoperatively for 3 days maximum for ICU patient. And this is a fully closed loop system that doesn't need any intervention. Other type of pump is the implantable insulin pump. This pump is inside, surgically inserted. It's there. It's already, there is 500 people around the world. They have this pump. They believe it is, as I mentioned, surgically implanted, and deliver the insulin to the peritoneal cavities, not to the subcutaneous insulin. They believe that this method is more rapid to deliver access to the liver than the subcutaneous insulin. However, it was owned by a small company called Minimed. Then Bidotronic buy this company in 2001, and they terminated by 2007, because I don't know, the study said that the safety issue, surgical, it wasn't, I don't know, patient does not like it in the market. They want something that is external, and that's why it was terminated. However, the foundation, they still asking for another company to have it and to evolve it, because there is a lot of things that need to be updated. and they are still having it. Other technology is the inhaled insulin. Maybe you heard about it, which is Afreeza. Afreeza is commercially available in US, but it is only for adult, and it was launched in 2014. It takes only 12 minutes, very flexible with the meal time, and the better control for the hyperglycemia postprandial. Although it looks very good, and maybe you are, I don't know, wondering why you did not hear about it before. I think because of disadvantage, it was not adopted by the healthcare provider because mainly of the pulmonary safety. You need a very good lung to use. You need to do lung function test before using this inhalation. So that's why it wasn't that famous and was very, very costly. And as you know, for adults, it will not make a big difference with them whether they use injection pump or inhaled insulin. So that's why it was not that popular in other countries. And this is the trial about the study about the inhaled insulin and how it was affecting. And even the result, to be honest with you, was not that promising. The results said that only 21% they achieve improvement versus 5% who did not use, who used the sub-Q, and while 26% they're worsening even. So that's why it was not that promising to have inhaled. However, they discovered that the people who achieve improvement, who's the people who was having high A1C from the beginning. These the people who get good achievement with this medication. And by the end of the study, there was 50% of them, they want to continue inhaled, while 50% they want to go back to the sub-Q insulin. And there is still further study. They want to study it in pediatric because they believe that it might have more success. However, the future-directed technology, there is now dual insulin pump. I'm going to talk about shortly. The inhaled insulin in pediatric, as I mentioned, a transdermal insulin, and stem cell producing insulin, and the oral insulin, which is mainly not for type 1, for type 2, but I think it will be for type 1 shortly. However, the emerging.
لو سمحت دكتورة، ودي لو حصل على عجل تمري عليه، لأن تجاوزنا الوقت شوي، علشان نحاول نواكب الوقت قدر الإمكان. أعرف أن الموضوع جدا مهم صراحة، لكن لعلنا أيضا نخصص بعدين ندوة خاصة بالمواضيع هذه ممكن.
Sure. So this is the dual hormones as either to have glucagon. هذه البايونيك الآيلت بامب. Now they are in the trial of having the glycagon with the insulin. Still the stability is challenged, but now it's in the trial. And there is another trial also supporting this. The other hormone is the amylin. The effect of amylin is to slow the gastric emptying. That's why they think it will suppress the postprandial hyperglycemia. Again, the stability, the cost, the complexity, and the occlusion of the pump itself, it's challenging. Other thing, we said that the inhaled insulin for pediatric, as I mentioned, they are still studying it for its long-term efficacy. There is a transdermal through multiple techniques. However, they think it's superior or comparable, but still under research. It's not commercially available. It's not in the market yet. And we have the glucose response insulin. This very interesting, صراحة. This insulin will switch on and off according to glucose. So whenever the glucose is low, it will switch off. Whenever it's high, it will switch on. They announced about it in 2024, and it's still in the preclinical stages. We are maybe within the 5 to 10 years. I think there is a future for this technology. And finally, and this is stem cell transplant VIX 880. They insert the stem plants through the portal vein, then with the immunosuppressive, then this stem cell will produce insulin in 90 days. And it's very promising, but the only thing disappointing is that you still need the immunosuppressive medication, and still in the research. And we have the oral insulin. It's mainly now studied. We know that the insulin absorption will not be good with the gastric. But now the nanoparticles, they are working on it just to bypass the absorption, and still in the research phase for the efficacy and not yet available for the patient. It was failed before, and they announced it was failed. Then after a few months, they announced that no, it was not failed for all patients. There is some selected patient where there is a successful, and that's why they put some criteria, and now it's still under trial. So they are looking for a brighter tomorrow. So in summary, we know that there is a technology, it's evolving with all its challenges. However, the technology will still close the gap between diabetes management and normal physiology. And I was planning to conclude my presentation here, but I add this slide, which I always tell my patient that although the future is promising, because some of my patients always said, I'm gonna wait. I will wait for Omnipod 5. I will wait for the batches Minimed. I will wait for the T-Slim. So I always tell them, although the future is promising, please don't wait. Waiting is not a strategy. Just deal with what is available. And when the new innovation come, please say welcome and enjoy it. And thank you, everyone.